So a lot of technologies that are developed, but actually are they fit for what the NHS is looking for, frontline priorities in particular, because the NHS is obviously not very good at outlining clearly what it wants on the front line. So it's very difficult for innovators to develop technologies for that. And the other problem early on is access as well. So actually getting into the NHS, getting a pilot is very challenging. There's a bit of a catch-22 as well, where you can you'll go in to try and get a pilot, and you'll be asked to present evidence that you would only get from doing a pilot already. So it makes it very difficult for innovators to actually access the NHS. And then as you get further down the maturity pipeline, then it becomes very much actually going from trust to trust or organisation to organisation, very slow and time consuming. There's no national procurement really, certainly not on the ground, very localised, generating evidence over and over again to present to different trusts, very slow. And by that point, investors have given up. So a lot of technologies just don't make it past that point, which is a real shame.
I think that point that Aaron makes about centralisation is really key. The fact that everything's done on a bit by bit. If there was some kind of hub or to pull it together or some coordination, that would make a big difference.
What's the single biggest implementation barrier, do you think?
I think one of the issues is culture, because it is really, as Aaron says, really difficult to get it embedded to start with. If you're only doing it bit by bit, it's really hard to get it going to scale. So that's a key problem, I think.
I think another thing is the support around implementation is a big problem. We have lots of funding going into new and exciting research and blue sky thinking, and that's fantastic. We want that. But we do need a little bit more going into the middle zone. Once you have a good idea and you've developed it and you've got your evidence, actually then implementing that in services is very difficult. It costs money. You have to think about NHS staff time, who's actually going to be delivering it, have they been involved, do they have any buy-in? These are things that also require innovation. So I'd like to see some of the innovation that's focused around new ideas and new interventions actually be sort of channeled a bit more to innovation around implementation. Are there smarter ways that we can implement, which cost money? So I think a lot of the time it does come down to public funding also going more towards implementation, innovation, rather than just lots of new ideas that can't actually get out into the real world.
These things often take iteration, and you think about the money that big tech put into getting products to the point where they can really saturate the market. There's that gap missing, whether that gap should be filled by funders or government or venture capital or some combination thereof. Is I think probably some combination of is the answer, but that's the gap.
So what we actually need are more blended funding models where you have venture capitalists agreeing that if public comes in and de-risks the implementation stage, they will provide follow-on funding. But at the moment, it's creating a gap where we have a lack of support during the implementation stage, which is precisely where we need the support from public and philanthropic investors to de-risk that pathway for private investors to come in.
What have you learned in doing digital youth about collaboration? What works and what should we avoid?
Well, I think the key thing that I've learned, and I think others have, talking to others around, have learned, is that all of these things need to be built in from the beginning. So, you can think, as a scientist or a clinician, you can think this looks like a great innovation in terms of how we're going to tweak therapy, or we're going to improve an intervention or come up with a new way of delivering it. But then at the same time, you need to be working with the users group who's going to be actually receiving it and making sure it fits them and they want to use it and they're going to engage with it, particularly for young people because they've got very different views. Then you also need to be doing that same thing with the providers, whoever they're going to be. Is that going to, whether that's charity sector or whether it's NHS or whether it's educators. And at the same time, you need to be doing that with folks who are setting policy, because otherwise it's not going to get funding from central spaces. And at the same time with potential commercial providers so that they can model these things out. So it's a really complicated process because you've got to be modeling all these different variables and all these different possible functionalities from the get-go. And I think we've all learned where we've tried things and we've done some of them but not others, and then you hit a point where it's, okay, this is a great new intervention, but no one's thought about how the business case for how they're going to support it in the long run to scale.
Yeah, I completely agree. And I wonder whether we can be more systematic about this. So for all these things to happen, you can bake it into the start and you can trust researchers to have this in their plan and to do it. Or you can have funders mandating it as part of the funding. So if you have a big funding call and say it's 50 million, if you can just siphon off 2 million and provide wraparound support with the funding to ensure that these kind of co-production processes are going on, and all the stakeholders who need to be involved are consistently involved from the start, and not just as sort of distant advisors on a grant application, but actively embedded in the process. And I think funders could do a little bit more to ensure that that happens.